control if you want to start.
All right. Let me give you guys a follow-up on that case I showed last week, because they imaged the patient again. And let me just bring up the two exams now. Let me just get off the sync mode. So just to refresh your memory, this is the person that had the findings of septic embolism, and there were filling defects in the pulmonary vessels, and I showed you folks this one curious one here where there was a little blip of air or gas related to one here in the left lower lobe right there. So this time they imaged the person again, but I'm not quite sure why. But the way that exam was done, it wasn't done with really great opacification of the pulmonary arteries. And I think, but I don't know whether they wanted to just look at the lungs again. But just let me show you kind of an interesting thing that I saw and see if you agree with me on the new exam. So I'm going to go down to here. So sorry, this thing's scrolling really fast, unusually fast. So look at this area, and I want to go to the same area on the prior exam. And I want to show you that area. So this is the current one. This is the previous one. And in relation to this vessel there, see what's happened here? This has developed. Now, where there was a normal vessel before, right here, opacified, now we have this. And if I go to the window like that, there isn't great opacification, but obviously those vessels are now bigger and they're quite gray. But again, on the lung window, there's something new there. So I noticed that, and then I started looking for the same phenomenon elsewhere. So I found a few places. Let me show you one other one. So now I'm scrolling up, and look at this area, for example, here. And let me go to the same area previously, which is up here. And in that location, now, also in relation to that bronchovascular bundle, it's really rather thick. And instead of having a nice vessel of normal caliber like that, look what's happened to that vessel. So I wish we had better opacification, but what I think is happening is that we have more vegetations, infected vegetations that are lodging in vessels, and there's a localized inflammatory reaction within and about the vessels like that. Let me go to this again, say like that. So I'm showing you right there.
Yeah, they almost look like pulmonary emboli where they expand the vessel, but I think you're right in that they're sort of infected clots, and you wonder if it's sort of undermining the vessel wall and you're starting to develop an abscess, or maybe it's just an inflammatory response. But yeah, that's really interesting.
Yeah, I don't know, Jeff. I'm glad you brought that up, because I mean, like we talk about all the time, that expansion of the vessel is a good clue to the presence of acute pulmonary embolism. And so I was thinking maybe it was just more embolic stuff that is expanding the vessels, but yeah, this may be causing inflammation around it too.
And remember, this is the guy with the large tricuspid valve vegetations. And I was thinking before that he had embolized vegetations, not bland emboli.
Right.
So that's really interesting, isn't it?
That's pretty cool.
So that's the way I read it out, and I may never know, but I noticed there was definitely a change in a couple places. There was another one up here where this vessel here had also increased in size with a little bit of opacity around it in the lung. This one too. Sorry about that. So that's really interesting. So let me show you a couple others. Okay, this is a classic. So here is the pelvis, but here is the chest. Let me show you the chest from 2017, in which we have findings of tumoral calcinosis. Going forward about a year, we see quite a bit more, but findings super typical of tumoral calcinosis. And there are basically two forms, and this one is certainly the chronic renal failure form of tumoral calcinosis. This patient does have chronic renal failure. I really don't know anything about these so-called primary genetic forms, but this person definitely has the chronic renal failure form of tumoral calcinosis. Just a really nice example of it, about the shoulder joints in particular. All right. This is a case of a patient with a history of stem cell transplantation and the development of extensive pulmonary parenchymal opacities. And of course, some of them are quite large. A lot of them are big, round, nodular lesions in the lungs, as well as smaller lesions. And this is what they look like. They're areas of necrosis within, particularly with respect to that lesion. And this one turns out to be this particular form of nocardia. I don't know how to pronounce that, but that's the form of nocardia that this is. So stem cell transplantation and this nocardia by virtue of BAL as well as culture positive nocardia. That, and this is this is one of the nocardias. So nocardia asteroides is actually a complex, a bunch of different ones, but this particular one is the one involved in this case.
So I think, yes, Siraki georgica. I've seen this a couple times, Howard, and in my limited experience of a few cases, it looks no different than the standard nocardia asteroides that we see. Massive consolidation.
Yeah, very, very large, multifocal, multilobar nodules, masses, pretty consistent with fungal or nocardia infection in this case.
Do you remember how far out this patient was from their transplant? You said it was a stem cell.
Let's see again. It's some time out. So the allo stem cell was March of 2018. Recently had a flare, presumably a skin or GI tract flare in September.
Okay. Yeah, the reason I ask is, we don't see it that much because they're early on, they're on prophylaxis for pneumocystis with Bactrim, which of course will usually cover most nocardias.
Okay.
So that's why I was wondering, because it looks like this is a GVHD, which would be a good time for them to get it because of the steroids they're on for it, and often the immunosuppression that the GVHD itself brings on, and they tend to be farther out, and they tend not to be on the Bactrim as frequently at this time.
Yep, that fits. All right. This is a very dramatic example of constrictive bronchiolitis obliterans in a patient with rheumatoid arthritis. So the radiograph is unremarkable, but I will show you that this radiograph, which is more recent compared to the one I showed you, which was from 2010, and you'll see this is really subtle, but I'll show you that it turns out that these airways here that are slightly dilated with slightly thickened walls turn out to be substantive in this person. So I'll show you the CT now from the most recent CT. And even on the thick cuts, you'll see that the findings of bronchiolitis obliterans are really dramatic. So it's super typical, severe, extensive mosaic attenuation. And the proximal airways, proximal generations like that are dilated. And this is pretty florid. Constrictive bronchiolitis, really classic. Her FEV1 is very low. So she's really unfortunate. But a very dramatic case of that. I think her FEV1 is something like 0.87. It's really low. Pretty bad.
Yeah, I found with the constrictive bronchiolitis, they seem to get the worst obstruction that we see more than we see with other chronic obstructive lung diseases. Like you said, FEV1's below 1.
Yeah. So she's probably headed to a transplant. It's just quite awful, isn't it?
Yep.
Yeah.
Howard, she wasn't on any sort of therapy like gold or anything like that.
Not that I know of, David. I don't have the detailed history in terms of medications, but she's a young person. I don't have her age here up there. I think she's in her 30s. Here's a nice anatomy case. So we have a person with a left SVC only. So we look and we start up here and we see there's no right SVC. Here's the left SVC. It goes to coronary sinus as it should. Of course, we're not going to have an azygous vein, but we're going to have blood flow coming up via the hemiazygous vein, an accessory hemiazygous vein. And the blood flow from the right side crosses the midline to that left SVC. So we've seen that before. This is just a really nice example of it. Left SVC, no right SVC.
Yeah, you sort of get depending on the size of it, the other one regresses in utero because it's not needed.
Okay, this is a curiosity. Let me just show you this just out of interest. It's not clinically important, but I was looking at this pneumothorax, and this is a post-biopsy pneumothorax after biopsy one of the nodules. And this was part of the further workup of the patient after metastatic disease was diagnosed. So at the time of the workup, which was soon after the biopsy, the pneumothorax is still there. I think the biopsy was the day before. And so I was just reading it as a staging CT. And take a look at this over here. So I'm going to go to now the mediastinal window and show you that this tissue, and I'll scroll up some more, that traverses the pleural space and is right in contact with visceral pleura. That is all fat. And I don't know what that is, but I think I've seen this phenomenon before and I never know what to call it. It's almost like there's a little bit of chest wall fat that is, in a sense, I don't know, sucked over or dragged from its location and touches the visceral pleura. I don't know what that anatomy is, but now I think I've seen it before and I don't know what to call that. But I think I've sometimes seen strands of tissue that traverse the pleural space in a pneumothorax, and this is the first time that I've been able to perceive that the bigger one is fat. So isn't that just interesting and curious? I'm not quite sure what I'm seeing or why.
So, Howard, I have seen something like this, and what's happening is that there's a little bit of a pleural adhesion there. So the visceral pleura of the lung is attached to the parietal pleura of the chest wall. Then when the lung is collapsed here, it's actually pulling on that parietal pleura, which is fairly stretchy. The
parietal pleura is right there. There's a fusion right there.
Yeah. And so basically the parietal pleura is being pulled inward from the chest wall, and it's very stretchy, and the fat is just following. So okay. It's a pleural adhesion that's just tethering this fat.
Something like that. Yeah, I can't imagine it being anything else. That's just really a curiosity, isn't it?
Yeah.
So I don't know why these things are popping up.
You know, Howard, you know the situation in which extrapleural fat outside the parietal pleura gets sucked into fissures.
Yeah, yeah.
And those long tapering wedges and stuff like that. That's still extrapleural, and it just shows you how stretchy parietal pleura is that it can be sucked into the fissure and the fat just gets pulled in along with it.
Yeah. Look at it. Look at these things right there, isn't it? And yeah, exactly. There it is.
Mm-hmm.
There.
Not,
cool.
Not that it has to do with pneumothoraces, but you wonder if that's the fat that gets torsed in mediastinal fat necrosis. Because they're showing it looks like it's on a little pedicle.
That's a good idea. I like that.
Yeah, I like it too. And also, I think sometimes we see these pluralists, and I wonder if some of this fat somehow necroses and calcifies, and you get a little pluralith.
Yeah, you've shown some of those pluralists before.
Yeah, they're fun.
You were calling them plural mouse or something like that?
Well, yeah, like a joint mouse, a plural mouse, but
yeah.
Very nice example. So this is an example of how plastic the fat is. So you know, the fat just fills all the spaces that are allowed in the chest. It's, you know, it's very pliable, it's very plastic, it gets molded into things. And the pleura sucks. So the fissures suck, and so they suck parietal pleura into them and stuff like that, and the fat just is part of that loose connective tissue. It's very stretchy and it just moves along with it.
very cool.
All right, Jeff, those are mine.
All right, who'd like to go next?
I've got a couple.
All righty.
So I have a scout view. Is the scout view visible to
It is.
our fans everywhere? Okay, this person has a smooth lesion in the left apex, and as you might expect from the CT findings here, showing that this low attenuation, around 10 Hounsfield units, fairly uniform low attenuation, has a little component that extends into the intervertebral foramen, that this is indeed a neural tumor. And this was resected, and it was a schwannoma, as expected, and that had been identified on a previous needle biopsy. So they already had the diagnosis at the time they did the operation. They did a combined neurosurgical unroofing of the posterior aspect of the spine. I think a hemilaminectomy or something like that, combined with a thoracic surgical procedure to get rid of this thing. And after all that manipulation, I was relieved to see that, you know, there's nothing left in the lung apex, and there's been no bad effect, say, on diaphragm or elsewhere. So a very clean resection of a schwannoma. So I like these smooth apical lesions. I wish I had a chest radiograph. I've seen, after motorcycle trauma in particular, I've seen pseudo-meningoceles in this location from avulsed nerve sheath, you know, what do they call that? The sort of capsule around the nerve sheath fills with fluid, and you get a CSF collection up here, a very smooth CSF collection. Been a couple of cases like that at Harborview in the old days.
Is it sort of from like a ligamentous soft tissue injury as opposed to the fracture, and it just fills in?
I think what happens is that the root sleeve gets torn a little bit, and fluid collects then in the extra pleural tissues and forms a pseudo meningocele up here. So it's not completely lined by meninges, because that nerve sheath capsule tore, and the fluid leaked out. So schwannoma in that case. And then here's this was a case that Eric Stern showed me, and then our fellow did a spectacular job of doing three-dimensional reconstruction. This young person was seen at Harborview because of trauma. I think it was a motor vehicle crash, and he has this lucency in the left apex here, and some abnormality of airway here, some dilation of airway, but he doesn't have a mucus plug up there. And on CT, he has low attenuation lung up there in that apex. It seems to be posterior segment of upper lobe. There's no mucus plug. There is an airway abnormality with dilation here, but if we track this, it gets very dilated up there. But as we track it down, and it goes medial, goes proximal, it disappears. So it does look like a bronchial atresia, in this case without a mucus plug. and this air trapping in the lung around it. So I don't know what happened to the mucus plug. That would make the pattern complete. And coronals are nice in this, because you see the local, pretty well-defined region of hypoattenuation, the dilated central bronchus, which then goes to nothing, doesn't connect up nicely with more proximal bronchi. I'm not seeing a lot of scarring here to suggest that this is a post-inflammatory problem, but I think that's in the differential diagnosis. And coronal is nice too, because it shows the sort of abrupt lower edge, I think, most nicely here of this abnormal airway collection. And then we did Jonathan Revels did these very nice color renderings of the differential lung densities here. And here's our lesion here, nicely shown in blue. So when we're looking at the lungs anteriorly, we don't see it as well as when we rotate the person posteriorly, we see the extent. It looked, initially on the CT scan as if it might be overlapping into superior segment of lower lobe. But I think what's happened is that the lung is expanded there where it's rarefied, and the fissure itself is being just pushed down. So I think that the fissure is a little bit depressed, and this is all indeed in posterior aspect of an apical aspect of upper lobe. So I think this color rendering is kind of nice, showing the different lung densities. Initially, you just shown the abnormal side, this left side with the air trapping, and I thought it would be nice to have the comparison of the other side just to show what normal lung attenuation would be as represented in this color map. And posteriorly, because of dependent atelectasis, we have higher attenuation in the lung. Isn't that cool?
That is really cool.
I was going to get water, some wallpaper like this. Okay, and then here's a young man, 30-some years old, who surprisingly has myelodysplasia. So he has MDS. I was just at a lecture this morning talking about MDS, and they said that the average age of MDS is 71, and this person is in his 30s. And they suspect that this is a GATA2 deficiency that led to his MDS. And GATA2 deficiency is one of the causes of the monoMAC syndrome. I'm finding out. So last week's lecture was on GATA2 deficiencies and other immunodeficiencies, and they mentioned monoMAC, which stimulated me to go back and retrieve this case. So this fellow was treated for his MDS, which had progressed to AML. So he was getting chemotherapy and he was neutropenic. He's got this diffuse lung disease, which at this outside hospital, which is not well characterized. It seems to be sort of central lobular little dots here. In the right setting, this could be hypersensitivity pneumonitis, a bad case of that. But in this setting, it's probably something else. It's probably an infection. And then he has this lesion here in the right base. And then just a few days later, that was the 24th, here is the 29th, 5 days later, you see that this lesion is much bigger. And it looks as if it may be developing a cavitary center. It's trying to be a bird's nest here. It's got that sort of lacy lucency in the center and then the dense rim around it. Very suspicious for a zygomyces. Things did not go well for him. Here's what his chest radiograph looked like. A few days later, he's now got a huge pleural effusion. He might have, this might be that cavity in that lower lobe thing, or it might just, I don't know, be a little aerated lung. And CT, this is one of the last CTs that he had before he was discharged. I doubt that he survived. You can see this lucency within the lower lobe reflecting probably that central necrosis that we were seeing, the bird's nest sort of thing. And at this point, he also has quite a bit of pericardial disease, and fungus was also gotten out of this. So this was a zygomycete, and it's a very strange species. I was trying to retrieve the species from the chart, and I'll have to include that when I post the case, because I couldn't find it in the few minutes before the conference here. But it's not the typical zygomycete species that you've heard of before. But the notion of that this fellow had a GATA2 deficiency, his insurance company did not approve the genetic testing for that. And I think that his clinical condition was dire enough that it probably wouldn't have made a difference to identify it because it was pretty late in his life. So this fellow probably has a GATA2 deficiency as a cause of very premature MDS/AML.
Yep, and one possibility for the diffuse lung disease is extramedullary hematopoiesis. That's always one that's worth thinking of.
Okay, that would be interesting considerations. Okay, so this person had a PE study, and there's an incidental finding that I want to ask you guys about. I wish that Seth were here to help me with this, but Matt Cham, our new radiologist here, who's joined us.
I'm here, Dave.
You're here, okay. Well, Matt, do you want to describe what we're seeing here?
Oh, me? Or I thought you said Matt.
Seth is here. Okay. Okay.
Oh, I'm sorry.
Okay. I'm glad you're here.
In the region of the coronary sinus, yeah. There's either.
He's calling it a coronary sinus aneurysm. Matt was wondering about that. Nobody's ever heard of that, so nobody in our reading room is familiar with coronary sinus aneurysm.
No, it's dilated. It just depends if it connects with the left atrium or not. But I can't tell from these slices.
We could not see a connection to the left atrium, and so it wasn't unroofed. The people did scrutinize for that. Here, let me show you the sagittal here. I think that helps bring it out. So here's our abnormality.
Yeah, my guess is it probably has to do with the severe elevated right atrial pressures, given the fact that the guy has pretty hypertrophied and dilated right ventricle. So the coronary sinus is a relatively low pressure. It's like right atrium. So if the right atrium is dilated, I wouldn't be surprised in cases of bad pulmonary hypertension if you can get some weird coronary sinus, I don't know, appearances. But I agree, it's definitely bulbous. I've seen cases like that where you have stenosis of the Thebesian valve and stuff, which is the valve that connects the coronary sinus to the right atrium. But again, that would be hard to see on a PE study.
Okay, so if the ventricular pressures are high, then wouldn't we expect more dilation of?
That's a pretty big right atrium.
That's big enough.
The RV's hypertrophied too.
The RV's, I mean, this patient definitely has pulmonary hypertension. I mean, the valve is closed, so the patient's on systole. You know, you definitely have some pretty severe, give me a seizure, pulmonary hypertension. And so the right atrial pressures must be very high. So I don't know if that has anything to do with it, but it probably makes it at least more conspicuous.
Okay. All right. Okay, so
at least that's how I would interpret it. I don't know if that's right or not.
We won't dignify it with aneurysm, but we'll say it's dilated and it probably reflects the high pressure.
And maybe.
Okay, very good. Well, those are the cases I wanted to show.
All right, thank you, David.
Thank you.
All right, Travis or Seth?
I can show mine real quick. Nothing that exciting.
All right.
You always say that, Seth, and then it turns out to be something
exciting.
Let's see, I don't remember what this case was. This was interesting. So here is this person with, we see this all the time, right? These weird, person's a smoker, has whatever you want to call this, emphysema, some strange cystic change, and then has a structure, and I always just assume it's this big focus of emphysema. But what was interesting is that, well, first of all, it's been increasing in size, which is not that, these do change, but this is many, many, many years ago. So this is about 8 years or 9 years before that. We can see it's increased in size. But what's fascinating to me about this was that we happened to get expiration imaging on this, and that thing completely collapsed down.
Wow.
So, let's see if I can put the two side by side. I can figure out how to do this on this thing. But yeah, it's just very weird. I don't. So here it is here, and has all this strange kind of internal architecture. And you could see, if you do scroll through on the thins, you could see that these dilated airways connect right into this structure.
Mm-hmm.
So, and then it collapses down. So I don't know what to call this. I don't know what it is pathologically, but I'm curious what other people call these things. I know some people say, oh, it's airspace enlargement fibrosis, which some of these probably are, but emphysematous spaces shouldn't collapse on expiration. So
I think the one thing that's important to say is it's not honeycombing, which sometimes.
yes, no, it's not.
Right.
Yes, it is not honeycombing.
That's what I'll call it. Is not honeycombing. Yeah.
Right.
There's some
Anyway,
not honeycombing in the left lower lobe. There you go.
Yeah, I don't know what. It just was really shocking to see that expiration go completely to nothing.
That is interesting.
But it's definitely smoking related. Emphysema.
Sorry.
It's definitely smoking related kind of emphysema, regardless.
Right.
Yeah.
But it's just emphysema shouldn't. I'm guessing emphysematous spaces don't really collapse because technically, even right, the respiratory bronchioles should be somewhat obstructed or destroyed from.
Well,
that's what Hogg was saying about emphysema, that you get lower, reduced numbers and destruction of the respiratory and terminal bronchioles, and the emphysema as a subsequent result, and thus, really you shouldn't see much change in the size of emphysematous spaces. Honeycomb spaces can decrease in size a little bit, but not really collapse. It's some smoking-related process. I don't.
Yeah.
I give up on a lot of these things. So this is a person with a bad lymphoma, which is itself kind of interesting because it's invading the pulmonary vein and extending through the pulmonary vein, going into the left atrium. He gets it treated and it completely melts away, which is obviously good for him. Let me just make so I pull these up in order. So lo and behold, the thing melts away, which is very nice. Let's see, so that's tumor. That is, so then it goes away, or nearly completely goes away. But what's not surprising is that right superior pulmonary vein is still where it was invading through and going into left atrium is out. I'm not sure if he was irradiated. I would have to check. I think he was, but he starts developing these patchy, areas of consolidation, some fuzzy ground glass around it. And you can also see that the lymphatics around the airways and the septa are kind of thickened in this lobe in general. The lobe is somewhat smaller. And if you look at the density, it's somewhat increased. And we'll see over time that these opacities kind of shift in their appearance. Here it's kind of breaking apart. You got a little bit of a crazy paving pattern with some of these areas. Again, the septal thickening. And they showed this to me in a conference, and then here this is a different area. So the other area is resolved. Now we're seeing, some curvilinear density. So I looked at this, maybe even some central clearing, and said this is going to be hemorrhage. And again, you can see the density of this right upper lobe compared to the left. And we did a RadPath conference, and they did a bronch washing, and the washing came back as literally was read as no malignancy or pneumocystis, which was fine. But then they showed in RadPath conference, and this kind of popped up from the bronch. And there's a lot going on here besides no pneumocystis or malignancy. We can see all of these hemosiderin-laden macrophages all over the place. The new red blood cells, who knows, that could be from injury, but this patient has clearly been hemorrhaging for a long time, fair amount of time, to see all these, hemosiderin-laden macrophages. So this is chronic recurrent hemorrhage.
Yep.
And I'm sorry?
Go ahead, sorry, yep.
So presumably he's somehow infarcting that right upper lobe. And normally, to have a pulmonary vein knocked out is really usually not a big deal. Normally you get good flow through the adjacent inferior pulmonary vein in this case, which is widely patent. And I'm not sure why he's not getting that good collateral flow, but over time you're getting recurrent hemorrhage. And so I'm guessing it might have to do with the radiation and stuff that they did to the hilum for the underlying lymphoma. So anyways, just chronic recurrent hemorrhage due to pulmonary vein occlusion and probably just slowly venous infarcting.
It'd be interesting to see if complete fissures were, were more prone to have venous infarcts like this, because that's what this.
That's a very good question. It's a good question.
Because, right? Yeah, a lot of times we see the collaterals, but this guy clearly looks like he has a complete fissure.
Yeah. No, that's a good question. I never even thought of that. Because we see veins go out all the time, and I very rarely see infarcts. The only time I ever see venous infarcts is when both veins on the same side are gone. So I'm not 100% sure. This is a cool case because it's just this is the biggest one of these I've seen personally, and this was called a cyst, which I kind of understand, but it has a very, very characteristic appearance where this is all fluid attenuation. It sits in this right paratracheal, and then as the aorta comes across, it kind of dives posteriorly, and this has been there. I have another study. This has been there for a long time, and this is just and you can see here that it's clearly, because of its location down here, it's intrapericardial. So this is a high-riding superior aortic recess. So you get these high-riding recesses that can get filled with fluid. We see fluid in the superior aortic recess all the time. But sometimes this outpouching, the ones I've seen have been much smaller than this. They go in the same exact location, the same exact location every time, the same appearance. And I've seen them go this high, but this one to be as filled as this, I've not seen. And again, you can see it kind of coming underneath where the aorta crosses over the PA. And it's just often, unfortunately, it gets called a cyst or some sort of, other abnormality that would lead to median sternotomy and them trying to resect just basically an outpouching of the pericardium. So anyways, that's an interesting one of those. And then, I'm sorry?
Great example. Sorry.
Yeah. On this one, sadly enough, even though it's absolutely massive, I think I would hopefully make the diagnosis on chest x-ray, but in retrospect, knowing where the abnormality is, I don't know why this doesn't. But there's a mass back here, which isn't showing up, big mass here. And just one of the bigger examples of this I've seen.
Was there atelectasis there on the lateral view as well?
Yeah, absolutely.
Oh,
so
geez.
This was a carcinoid, an endobronchial carcinoid. It's just one of the bigger carcinoids I've seen. And we know carcinoids don't have to be endobronchial. They were thought to be, most of them being endobronchial, but I think that's kind of shifted. And the one thing to suggest a carcinoid is the enhancement. So carcinoids, we know, are highly vascular tumors. That's why they take up synaptophysin but they're highly vascular tumors, and so the enhancement in this is pretty good.
Is that contrast or is that calcium?
That's calcium.
Yeah, that also is.
That's calcium. Yeah, but I'm also saying
right in there.
Yeah, that portions of it internally and elsewhere enhance pretty good.
I think that calcium's a good look for it too. It's sort of that, it's not a benign pattern, but more of that sort of stippled, whatever you want to call it.
Yeah, no, 100% that's calcium. But a lot of the other areas are very, as bright as the aorta, or brighter than the aorta here in the pulmonary artery on this portal venous phase study, which is another good clue for a carcinoid. So that's just one of the bigger carcinoids I've come across.
Hang on, Seth, before you go away. Can you scroll down to show the interventricular septum here? There's not that much contrast on board. It's pretty, as you said, this is late.
Yeah, late. It's very late.
So, okay, we don't have a non-contrast study to see how much calcium there is.
Yeah, we do. I just wasn't gonna. I do have one. Do you want to? I don't have it included.
You should be able to see some of that calcium on the radiograph too.
Yeah, you can. I just. But
is it only taking out the lateral segment of the right middle lobe?
So here it is. Here.
Yeah.
Let me go.
Because you can still see the right heart border, but you see that little band of atelectasis there.
Let me see. And I do. It's funny. I do have non-cons, but I'm like, non-cons not interesting. I'll just include the contrast. But I'll go back and download it and send it over. Yeah, but is it just taking? No, it looks like the whole middle lobe is
contrast. I mean, that's clearly calcium.
What?
It's just that the right upper lobe anterior segments coming down along the heart, which is why you still see the right heart border.
Yeah. But if you look at the portion that extends into the bronchus, for instance, like here is an endobronchial component. And anyways, it's quite bright, looking at it. So yes, it is extensively calcified, and that is another thing for carcinoid, but also the degree of enhancement of the lesion. And I do have non-contrast to show that both the enhancement and the degree of calcification.
Cool.
Yeah.
All right.
Okay, those are mine.
Thank you, Seth.
Jeff, also too quickly to save you some time. I have a bunch, but I'll try and show the best.
About 15 minutes, so you can go longer if you like.
Okay. Now this portion of this case I've shown before, but it ties in nicely to both Howard and Seth's cases that have been shown. So this is a patient that had a redo lung transplant. So he had rejection of his first lung transplant, had a redo, and I showed this last summer. He had persistent consolidation in the left lower lobe post-transplant, wasn't doing that well. You can see there's ground glass consolidation, and when you interrogate the pulmonary veins, you will see that the left inferior pulmonary vein is out, and there's a little bit of thrombus even extending, it looks like, into the left atrium. And the surgeon wasn't really surprised because it was a redo lung transplant. There were a lot of adhesions. She tried to reconstruct this left inferior pulmonary vein. So not too dissimilar to Seth's case of the pulmonary vein occlusion being caused by lymphoma, but in this case just iatrogenic. But I show that because I have more information on this patient. I was reading another follow-up study on him, and I saw an interesting history which tied into his original lung disease back in, well, before 2010. And so he was, I don't know how old at this time, in his 30s, I think. But this ties into Howard's case, that we see that there's some bronchiectasis, and it's more severe in some areas, some cystic bronchiectasis. But you can see just the diffusely decreased attenuation in some areas of relatively normal attenuation. So mosaic attenuation, severe obstruction, severe obliterative bronchiolitis. And the reason I even went back and looked at this study was the history. And so, David, you mentioned gold as a cause. Another rare drug that is, this guy wasn't on gold, but you know other rare drugs that you include on that list of obliterative bronchiolitis.
I can't.
Penicillamine?
Yep, this guy has Wilson's disease and had been on long-term penicillamine. And so, of course, Wilson's disease is inability to excrete copper, and so you treat with a chelating agent like penicillamine. And so that's what he had as the cause of his obliterative bronchiolitis. So this was the first case I've seen of confirmed penicillamine causing obliterative bronchiolitis.
Oh, I didn't know they used it anymore.
Yeah, this was probably 5 or 6, or well, I guess this was 2010. So 8 years ago was when he had the transplants. I have no idea how long ago they stopped, but when I was looking, it still sounds like it's a treatment.
Okay.
Of obliterative bronchiolitis.
Of
Wilson's disease, right? Yeah. Now this one's kind of interesting. This just came in this week, and this is a radiograph case, and I will show you 2 radiographs side by side. So this is a patient who had an aortic valve prosthesis a long time ago. And I think this is why it's always important to, I tell the residents not just, say there's a valve, but figure out which valve it is. And you can see on both of these that this is in October and this is now December. And you can probably see what the difference is here. And this is one of the better radiographic examples of this that I've seen. Howard, you were going to comment?
Oh yeah, the orientation of one of those devices is changed, or both.
Yeah, well, I think this is the only valve. I think these are just vertical median sternotomy wires.
Oh, okay.
Yes. And what's also interesting is this radiograph on the 8th. Let's see, this series. He had a series of 2 radiographs taken a couple hours apart. These 2, and this were both at the outside. And you can see the orientation is even changing over the course of hours. And it's not surprising, of course, the change in orientation is an indicator that the valve has dehisced. And this patient in the past had gallstone pancreatitis last year, has had several recurrent infections, and now comes in septic and hypotensive. Right. And this is the CT that he had shortly after those radiographs, and you can see he's got a lot of volume on board now. And the aortic valve prosthesis, not surprisingly, there's a big vegetation surrounding it. But not only that, you can see there's not one, but two fistulae. There's one to the left atrium right here, where you can see there's a channel right there, and that there's a second one right here to the right side, to the right atrium, kind of right near the tricuspid valve, the septal leaflet. And the valve, let's see, this was not a gated study, but you'll see, you don't, just by definition, this thing, is at least partially dehisced based on the change in angulation. And you can see it's much more vertical or horizontally oriented on this than it was before.
Were we seeing the filling defect in this plane from the vegetation, or was it an artifact? So
this is all vegetation here, yeah.
So Travis, do you think the orientation of the valve prosthesis is changing on those radiographs because we happen to be catching it during a different part of the cardiac cycle, or do you think it's actually actively moving, or it dislodged at that point?
Well, I think it's actively moving. On echo, they even said that it's just rocking when they look at it on echo. Yeah, so that's not and this guy's so sick that he needs a valve replacement, but he's too unstable. I was just going to try and do a quick reformat on the plane, and I think you'll see the extent of the valve, the amount of the annulus that's dehisced. Yeah, and I think that probably a good portion of this has dehisced because you see contrast really on both sides, above and below the valve. So, and of course with a mechanical bileaflet valves versus bioprosthetic valves, this is typical to see infection or abscess of the valve ring in these mechanical valves, whereas bioprosthetic valves, often you'll get endocarditis with valve leaflet destruction. But yeah, you can see that big vegetation there when you reformat.
Gosh, yeah.
Okay, I'll show one more quick
all right,
radiograph case, and then I'll let you finish up here. This is just a quick one. Again, I think it's always important, though, to show little eye tests, because this one also shows the value of the lateral view. So this is a patient. You can see she's got a port catheter. She has breast cancer. We have 2016 and 2018, so I'll let you take a shot. Howard, I know in particular you like trying to see what you see on these.
Yeah, at the level of distal left main bronchus to the left of the spine is a new mediastinal lung interface that is different from what it was before, and it extends superiorly.
Yep. Well, and this is also a reminder, and it's one of the first things, it's why my search pattern on the lateral, usually the first thing I do is run down the spine. And so you can see, again, 2016, 2018. So you can see what's happened that right at that level. Yeah, so it's a lot more obvious on the lateral view. It's still pretty subtle, but you can see there's a new vertebral plane or near vertebral plane at this level. As you see end plate, and then kind of an end plate right here, and this vertebral body that's just squished. Because you can see that there's the posterior aspects in the ribs here. So this patient, not surprisingly, came in with neurologic symptoms, and I'll just show quickly on the CT that here's what you're seeing, that widening of the paraspinal interface there. And this was just a new pathologic fracture from metastatic breast cancer, subsequently confirmed when they did a spinal stabilization surgery. So just always a good reminder to look at the spine on the lateral view.
Yeah, can you show that PA again, Travis? Just
sure. Yeah, I'll show the PA and the lateral side by side.
That'd be great. Yeah, it's a nice but subtle.
Yeah.
Melody.
Yeah.
But the convexity is the tumor around the bone, around the destroyed bone.
Correct. Or tumor, blood, whatever it is from the presumed, at least relatively acute pathologic fracture. Yeah, exactly.
All right.
Okay. I'll stop there.
All right, I'll show a couple. So the time we have left. All right, so this is an interesting case. So this is a 50-year-old female who has trisomy 21 and a long-standing history of heart disease, and this is the most recent chest radiograph. And you can see there's big heart, there are big pulmonary vessels, very, very plump, so almost looks like shunt vascularity, some pleural stuff going on. I've got a bunch of CTs, but I'll just show, I'm going to show, let's see which one. I'm going to show this one just because it's not expiratory. Has had a history of a couple of infections, but what I want to show are some of the congenital anomalies. So ignore the consolidation. So we got an aberrant subclavian, which is not particularly interesting, but this is cool. You've got this vessel connecting the aortic arch or the aortic isthmus with the pulmonary artery. So a nice patent ductus. And I know David always likes to point out the atherosclerosis in it, high pressures for long periods of time. And we've got severe pulmonary hypertension. She's got Eisenmenger physiology. But what else is cool, and I may have to switch between CTs to show everything, is she's got this VSD, so perimembranous VSD here, really thick RV. But there's also communication right down here. So there, it looks like an ostium primum ASD, so it's part of the endocardial cushion defect that's associated with trisomy 21. Patient also has 11 pairs of ribs, which can happen. And then they can also get a hypersegmented sternum. She doesn't, well, hers is fused, but when I'll just pull it up real quickly. It looks like at least at some point there was another ossification center in that sternum. Hard to say for certain, but yeah, so 3 shunts, ASD, VSD, and a PDA, long-standing untreated. I don't know the whole background why it wasn't treated. I believe it was I don't know if it was a foster kid or something, like there's some social situations or not, but severe Eisenmenger. So that was kind of fun.
Yeah.
Those different things. And then along the line of congenital stuff, since we were talking about that, you know, we always like to talk about the hybrid lesions. This is one that was picked up in a trauma, and honestly, I don't know exactly what we would call it, but clearly there's abnormal disorganized lung that looks like it got a little bit of an injury because there's some fluid and blood in it, but there's some abnormal airways in this. And additionally, we see hyperexpanded, hyperlucent lung. And then if we follow the airways, here we are at the right upper lobe bronchus. It looks like everything that's supposed to be there is there, but this doesn't really hook up to anything. So I think this is a CPAM with bronchial atresia in it, and probably some congenital lobar overinflation or hyperinflation, sort of all combined together. And it's sort of it seems to be middle and upper lobe, but in that probably a little bronchocele there throughout it. So this is just a big one. Unfortunately, I don't have a radiograph because that would be really nice, but I think we just see a hyperlucent right lung. I don't know if anybody has any thoughts on this. Here's the coronal.
Looks like there's something in that left base too.
Yeah, I think that's some air trapping maybe. It doesn't seem to have any funny airways, but you can see this thing seems to have some sort of rim to it, or at least some mass effect. But I would call it, I think it's all three. I think it's bronchial atresia that led to abnormal lung, and because of it, so you get the CPAM, but some of the lung was structurally normal, it's just overinflated. But this was, I can't remember how old, 40 years old, so incidentally detected.
Interesting. Very interesting.
All right, and then along our earlier discussion, I thought I'll just show this quick case. This is a nice pitfall case, or when we're talking about the fat, assuming I can get it to actually open up. Come on, there we go. So this is a chest radiograph that was done for a cough or some generic reason, and the interpreting radiologist commented on this apparent nodule here, and I don't disagree that there's an abnormality. You can see it's got a straight line associated with it, but you know, we know things like to hide along ribs. So patient ended up getting a CT. They may have had a risk factor or something, maybe a smoker. There's no nodule, but you can see what we're seeing actually is this extrapleural fat being pulled in. I'll show it on the soft tissue. You can see it as indeed fat. So fat not in the fissure, but in the fissure. So it's extrapleural fat being tugged into that little space. And you'll notice there is a little bit of volume loss in that right upper lobe. There's some scarring anteriorly. So as David says, it sort of tethers it, and it'll fill the space, and the parietal pleura will stretch. So yeah.
So you know, I I was investigating, fresh cadavers for a while when I was back in my Duke days, looking for these anatomical correlations. And it's just amazing. You can pick up the parietal pleura on the diaphragm, and you can just sort of pull it up with your fingers and stuff like that, and stretch it. It's very, very stretchy.
Mm-hmm.
The pleura has to be stretchy because the lungs are expanding all the time. Things are moving around. So extrapleural, the parietal and visceral pleura are nice and stretchy, and therefore it's easy to suck fat into the fissures.
Mm-hmm.
And this is a very nice example.
Yeah, you can see actually in two places. There's another area right there.
Right.
There's some weird accessory fissure here, which is just throwing everything for a loop.
But I can tell you hesitate to use the word suck because it has other connotations, but that really forcefully explains what's going on here. It gets sucked into the fissure.
Yeah. All right, guys.
Thanks, everyone.
Yeah.
Lot of cases.
Talk to you next week.
Thanks.
All right.
See you.
Bye-bye.
Everybody.
Thanks. See you guys.